Good afternoon, ladies and gentlemen, and welcome to the RCM chat room, where we discuss all things revenue cycle management. If you work on any part of the physician revenue cycle, then this podcast is made for you. My name is Latrice Freeman Baker, and I am the host for today's chat. In today's discussion, we will be talking about this year end push for risk adjustment coding. Now, we know that all you coders and CDI specialists out there are working feverishly to help your providers identify and code for all eligible diagnoses by the end of this benefit year so that you make sure that they can get the highest eligible risk adjustment score possible, and then hopefully in the end get the highest reimbursement from insurance companies that is possible, especially from the Medicare Advantage plans. Joining me in today's discussion is my beautiful friend and colleague, Shantae Lewis. Now, Shantae is an absolute expert when it comes to risk adjustment coding. Welcome to the chat room, Shantae. How are you feeling?
I am so good and enthusiastic and happy about this. I'm just happy to be here.
Well, thanks for joining me. I really appreciate having you on. Why don't you tell us a little bit about your revenue cycle background?
Well, I don't want to date myself.
Okay.
Okay. But I got 20 years. I've been in this field for about 20 years as a healthcare professional, and I've held various leadership roles in a variety of healthcare settings,
Okay.
including inpatient, outpatient professional services,
Mm-hmm.
and inpatient on the facility side as well.
Wow.
Um, I've been a part of a bunch of different HCC coding projects. I've done some practice management. And so now I've kind of just been an expert in creating auditing and education departments for hospitals, teaching facilities, small and large physician based groups of
Mm-hmm.
different specialties. And I've even stepped on the dark side,
Okay.
on the payer side for a
Oh,
while too.
I'll forgive you for that.
I hope everybody does. It was an experience. But yes,
Eh,
I was over there too. So yeah, I've kind of just had my hands in all different pots in a rev cycle.
Wow, it sounds great, and I'm sure that although all that experience pays off, and why you're an expert in what you do, so it's such a blessing to have you with me today. So I guess we should dive in. Are you ready, Shantae? Let's talk revenue cycle.
All right.
All right. So, Shantae, as I mentioned earlier, the race is really on to get risk adjustment coding wrapped up for this year to at least capture all of the appropriate diagnoses by the end of this benefit year. And for those out there who may be new to risk adjustment coding and HCCs, I really would like to start off by discussing two important questions when it comes to adequately and accurately reporting diagnoses for risk adjustment coding. First of all, I guess we should start off by explaining what risk adjustment coding is and how it relates to hierarchical condition categories, aka HCCs, and then why is capturing HCCs so important to the livelihood and stability of a physician practice. So, my first question for you, Shantae, is what important role does HCCs play in healthcare practices today?
HCCs is extremely important, Latrice. Very, very important because HCCs is painting the picture to the insurance company how complex this patient is. It's going to communicate the patient's complexity. That's the patient overall health and long term complexity of their treatment. It's going to be the measuring and of the quality and cost. So this tells the plans the cost performance by accounting for differences in this patient complexity. And it's going to be predicting, resource utilization, development of that healthcare system preparedness. So this is very important in healthcare practices today, HCCs.
Wow. So now when I think about risk adjustment coding, my mind always goes to a Medicare population. So I wanted to ask you, are HCCs important only within like an ACO, which for my listeners out there stands for an accountable care organization? And of course, these organizations work with Medicare to provide high quality care to their Medicare patients. So is this just ACO focus, or has this concept of risk adjustment coding branched out beyond that scope into like the commercial insurance space?
It has branched out. It is in commercial, and guess where else?
Where?
Medicaid as well.
Wow.
Medicaid has their own set of diagnosis codes that they are accepting for their patients, also known as HHS.
Okay.
They have their own set of codes that they look for their population. So it has branched out into commercial and Medicaid as well.
Wow. So it's beyond just people who have Medicare. And I think that was an important question because some people may say, well, I don't have, many Medicare patients, right? My patients are pretty, the younger population. But if it's branched out beyond Medicare, this is something that's going to be important for pretty much any physician practice out there who at least has to report or are reporting these risk adjustment codes. So tell us a little bit about the timing of capturing these codes for HCCs. Is this a process that is like one and done? In other words, how often should these HCCs be captured?
That's a good question. So some places is one and done. You do a reporting one time a year. Some places it's twice a year. Kind of depends on the plan. It
Okay.
depends on the plan you're with. Um, that's why usually when you're in organizations where they have this huge push toward the end of the year, that is because they're trying to capture anything in the beginning of the year that they did not capture, those suspected conditions that were not captured at the beginning of the year. So a lot of organizations have that one time, and usually January, February, they trying to push as much as they can. But then again, you have the end of the year where they want to try to capture any potential um, revenue that possibly was not captured, and that's where those suspect tools come into place, where that helps to possibly capture anything that did not get in the beginning of the year.
And I'm assuming when you say year, you're talking like calendar year, like January through December, correct?
That is correct.
Okay. So why is yearly reporting really important and imperative for a physician practice?
So again, it goes back to this is going to show them, not only the payer, but them, how much it costs them to treat or maintain this patient's condition. So that's why it's so important for the physician practice, and it gives them a better look and for them to see how sick truly their population that they see that comes in, as well.
Very good. And so I'm also thinking about those physician practices, some particularly small physician practice, where every little chunk of change helps, right? So
Hmm.
especially these solo practices or small practices where their bottom line is very important in the sense that they may need to hire staff or replace outdated equipment. So if they don't report their HCCs on time and accurately, this can actually hurt the reimbursement that they could be due within the following year. Is that correct?
That is so correct, Latrice. That is so correct. This is why it's so important to for them to maximize that time with their patients when they come in and utilize their suspect tools or whatever tools that they have. I know Epic uses something like a BPA, and it helps them and it guides them to kind of what they should or should not be addressing in that visit with the patient. So yes, it is very important, very, very, very important.
Now, when I capture my HCCs, let's say I finish all, I think I'm done by November. If I submit it, everything in November, can I expect to be paid like in December?
Well, we would all like to be paid when the payers tell us they were doing it. But no,
Okay. So how does that work?
no,
When is the payment
not at
year?
all. You'll probably get it like early the following year,
Okay.
January, February. Yeah, but we would all love for it to be done in December 30th and get a check cut December 31st. But no, that's not how it works.
Okay.
So yeah, wishful thinking.
Yeah, so submission year is different from payment year then it sounds like. So I get everything
Hmm.
in by the end of this year, December 31st, but I don't expect payment until 2025. Is that what I'm hearing?
Yeah.
Okay, I guess I gotta wait. Now, does the HCC code capture come only from primary care practices? So let's say I have a practice and I have primary care, and maybe I have some cardiologists there, or maybe some endocrinologists. Is it just the primary care physicians and APPs that should be worried about HCC capture?
No, specialists can also. Because so what happens is, uh, when you get that patient chart and that PCP is seeing the patient, usually in that chart, if that patient is seeing a nephrologist, you can capture, if it has not already been done so, you can capture any risk code that were documented and supported from that nephrologist or cardiologist.
Okay,
Yeah.
very good. So is it a so this is kind of a side question. Is it a case that a patient comes in, and so you mentioned Epic, Epic is like huge in the EHR space. And so we have a problem list. Can't we just, use the problem list and just use those for our HCC coding?
Uh-uh. No, no, and no. Because as you know, Latrice, that problem list is not always updated.
Okay.
Yeah, so now if you one of those groups where your auditing team and CDI team and you have your physicians on top of updating that problem list and it is updated yearly, by all means, please send me your plan and so that I can disseminate it to other organizations. But if that's not the case, then you should not be using that problem list because, again, some conditions could have been resolved and have not been taken off,
So
the problem list, or even clearly documented that has been resolved.
so how do I know which codes to pick then for HCCs?
Well, so there is only a group of codes that are risk, and you would have to get that group off of the CMS website. It's a
Okay.
huge, massive spreadsheet with all the diagnosis codes that CMS take. And then you would need to look at your documentation and see, do you have what we like to use, the acronym MEAT, MEAT,
Okay.
to support that diagnosis code. And so what MEAT stands for is monitor, evaluate, assess, and treat.
Mhm.
So you're looking for that for every single diagnosis code that risk.
Okay.
Yeah. So that is how you're going to see if it supports or not. You have no meat, you can't use it.
So as a risk adjustment coder, I should always ask myself, "Where's the meat?" Okay,
That's right.
that corny joke is telling my age, but you get the picture. We should always look for for those that's actually being monitored, evaluated, assessed, or treated by the provider. That's a good reminder. Where's the meat? Okay, I'll
But
stop
you know
saying
what? Think of it like this too, Latrice.
it. Okay,
Even outside of HCC coding, we should be looking for that from our providers.
yeah,
You know, it's just something that I like to also throw out there. We should also be looking at it no matter what, not just for risk, but
yeah.
across the board.
It's like the rule of coding period, not just for risk adjustment. It's for any coding. If I'm coding a surgery, if I'm coding an E&M visit, I always need to go back to my documentation and make sure it's substantiated. So I get it. The concept still applies.
Yeah.
Okay. All right. You got me. You got me. Thank you. Thank you. So let me ask you this. We do, and we're kind of alluding to it now when we're talking about what we need in documentation. What are some of the challenges that you've seen in risk adjustment coding, especially when it comes to that accurate HCC charge capture?
Number one, meat.
Yeah, me. Okay.
Oh man. And coding to the highest specificity.
Okay.
Those would be the top two biggest challenges in risk coding that I've seen. A lot of times our providers give us that unspecified,
Yeah.
and we can't use that. We
r-
need further specification for that depression. Is it
Right.
recurrent? Things of that nature. We need that specification. Diabetes. If it's just regular E11.9, okay. But this patient got some hyperlipidemia going on or
Right.
lipidemia going on. Okay, so Is there any linkage between the two?
Right.
That is what the specification needs to be there, the linkage needs to be there. Um, and that is and we make a big deal about it because guess what, Latrice?
What's that?
It affects that pay
Okay.
for that code. You're going to get a different pay, especially if that code is not within the same grouping
Okay.
other codes. You're going to get a different pay. And that
Okay.
pay can be an substantial amount of an increase, that you would need. So that's why coders, auditors, educators, CDI specialists, we hate to be a nag, but it's so important that you give us the highest specificity of those diagnosis codes because we're trying to maximize your reimbursement.
Yeah, so it's a difference. Sometimes doctors are flying through their notes, or nurse practitioners, or whatever. They may be flying through their note and they might document diabetes. And then, we may notice some other things, but we can't code it if it's not there. So you're telling me that if a provider, there's a difference, there could be a difference in payment if a provider just documents diabetes versus documenting diabetes with some other complications. Is that what you're saying?
Yes, that's exactly what I'm saying because the more complicated that patient is, the payer needs to see that so that they know how to reimburse you for
Okay.
continuing to manage that chronic condition. So,
Yeah.
yes.
Specificity. I like it to the highest level of specificity. So we talked about the challenges, right? It's easy to talk about the problems, but let's talk about some solutions. So what recommendations do you have to ensure that a practice captures these codes in a timely manner?
If you have a BPA, like they use an Epic or some kind of suspecting tool, or because you can also get those suspect lists from your payers as well,
Okay.
whomever you send it to, utilize it. It is such a good starting point.
Okay.
Such a good starting point because that stuff is all claims data driven.
Okay.
So somewhere in that patient's history, somebody said that patient had that condition. Now, it may not be true anymore, but it gives you a starting point
Right.
to start looking. I would say start there. That is a good starting point. And again, utilize your coders. That
Yeah.
is what they're there for. Utilize those coders.
Okay. All right. So my next question is a little off topic, so bear with me here. I just it's when I hear HCCs and risk adjustment coding, for some reason, I also start to, in the back of my mind, think about HEDIS measures. Now,
Oh, yeah.
how do HEDIS measures fit into all of this, if at all?
So HEDIS means like healthcare effectiveness data and information set, right? So
Okay.
it's a tool that they use to measure the performance of the health plan.
Okay.
So they're measuring health plans. So they're going to look at that care quality,
Okay.
the act like does this patient have access to good care,
Okay.
and the utilization of that. They're looking at the accreditation of the
Okay.
health plan, the Medicare star ratings, okay, and then the public health. So they're going to be looking at public health issues like cancer, heart disease, etc.
Right. Right.
Yeah, so HEDIS is very important. But they are looking at it on the plan side,
Okay.
versus the actual provider. They're looking at it as a
Oh,
plan as a whole, how well that plan is doing. Um, but yes, extremely, extremely, extremely important. Very, very,
okay.
very important. Yeah.
So I know it's a little off topic because, like you said, it's for plans, but I thought I would bring it up since it always kind of floats in the back of my mind when we're talking about capturing maximum reimbursement. So let me get back on topic here to HCCs and risk
Okay.
adjustment. What are some tools that providers and practices could use to kind of make sure that they're coding to the highest level of specificity in HCC coding?
So a lot of organizations are using a CAC. That's like
O-
a computer assisted coding tool.
Okay.
And so what it does is there's certain algorithms that are built in to look at a chart, and there's certain words or verbiages that this algorithm will pick up, and
Okay.
it will suggest HCC for the coder, right?
Okay.
The coder go and look to see. if that suggestion is actually accurate.
Okay.
So those helps a lot because those make the coders a little bit more efficient where they can
Okay.
do a little bit more. But I'm a little old school, and you can't go wrong if you got you a good seasoned HCC coder scrubbing that chart. That's just me. Because those, look, the cats can suggest all kind of crazy stuff. And you look as a coder and you be like, nope, nope,
Right, right.
nope. But you as a coder, you looking at that chart, you know what is supported and you know what risk.
Yep.
So I always suggest to get a good seasoned HCC coder, a good and credentialed. Let
Right.
me make that clear too. Credentialed seasoned HCC coder.
Very good. And I know I remember when CACs came out, and you're right. Because they're using algorithms to try to pull in this language or this language learning system. Sometimes we got results that wasn't 100% accurate, and so I always hear in the industry how coders are. They were afraid of computer assistant coding, or now the big pushes on AI. You still need a coder to validate the information that the CAC or even some of these AI tools are spitting out, because a machine can only do so much, and there's nothing more useful than the human brain. And so I think I know this is still me venturing a little bit off topic. Coders, it's okay. You are still valuable. These
Right.
tools that Shantae mentioned may make your work more efficient, but we still need good seasoned coders to review this
Yes.
information to make sure that it's valid, that it's substantiated in documentation. So very, very good point, Shantae, that you made there. I know I've held you hostage for a while. I only have one more question for you. Sorry if you bear with me. Where could a clinician or a coder go to find out more information on risk adjustment coding or even value based care?
You can go on CMS. On the
Okay.
website, go to CMS website. You can go to the AAFP, the American Academy of Family Physicians.
Okay.
And coders could really utilize the AAPC. I mean, they got some, AAPC has some great information about risk coding. They even have a risk coder certification, which I would suggest if you are a coder and you are specializing in risk, I would always suggest to
I
get
got
that.
mine.
I do too. I would always suggest to get that CRC risk coder. But yeah, I would start with CMS and the American Academy of Family Physicians and AAPC. Those are
Very
some
good.
good starting points.
Yep, at least to get a background on risk adjustment coding, what to watch out for, the importance of it. I agree, especially that CMS. Well, CMS has all things that you need to know, but if you need someone to break down what all that really means on the CMS website, I agree. AAFP always has great information, and of course, AAPC. I'm always going to put a plug in for them for some good information on risk. Shantae, this
Hey.
comes to the end of our discussion, my dear. I really,
Oh,
really would like to thank
okay.
you for joining us in the RCM chat room. I am sure this is not the last time I am going to see you here.
That's right.
I hope that
We'll
you
see me
come.
again.
Yes, I hope that you come back and so we can address some of the other topics for the revenue cycle. I think you and I share a similar history that we've probably done just about everything there is to do in the physician revenue cycle, and even dabbling a little bit on the facility side. I know I worked in some revenue integrity worlds. I mean, I think we can we have some good information to offer. So please welcome back. You're always welcome to join us.
Thank you. Thank you. This
You
is
are welcome.
awesome. This has been awesome, Latrice. And this is awesome for coders out there, who want to get their feet wet. This has been fun and awesome. Thank
Thank
you.
you so much. And thank you again, ladies and gentlemen, for joining us in the RCM chat room. We hope to see you again soon. Bye bye now.